Top Bed Talk.
Got a session today on implementation, covering research, clinical implementations and so on. We'll have plenty of time for panel discussion afterwards, so do put your questions on Slido. First, great pleasure to introduce our first speaker, talking about implementation of trial results and evidence base. So it's Joyce Yeung from the Midlands. She's a anaesthetist and intensivist based between Birmingham and Warwick universities. She's a clinical trialist. She's recently completed recruitment ahead of schedule to one of the largest RCTs of intravenous versus volatile anaesthesia, which in itself is, as anyone who does trials know, is a massive achievement. And there's many published trials out there. She has been director of our UK Perioperative Medicine Clinical Trials Network over the last few years. And now with the merger into the Centre for Research and Improvement of the Royal College of Anaesthetists, she serves as an associate deputy director of that unit there as well. Lastly, I think importantly to say, she's been exceptionally modest about it, but join me in congratulating Joyce for a very recent promotion to Professor of Anaesthesia and Perioperative and Critical Care. So it's a great pleasure to welcome and congratulate Joyce.
Thanks, Mark. Hi, everyone. Thank you for inviting me to give this talk. As I walked through the park today, I realised that the hotel opposite behind the scaffolding was the first hotel when I first visited the UK. We stayed there. It was not the nicest at that time. It looks even more run down now. That was in 1986 when my sister came to study UK, so it's going back a long time ago. So blast from the past. But yeah, thank you for inviting me and for the kind introduction. I've been given this topic, which I thought was interesting. I'm not an implementation scientist. Like many of you, I'm a clinician. I enjoy research, so I'm a researcher. As I look more into the topic, as I prepare for a talk, and obviously from working as a researcher and clinician, I take on board why this topic is relevant to all of us. Thank you for joining me on a Thursday morning. Let's start with whether we've got a problem with implementation. We're not adopting the guidelines and we may not be providing the best evidence base. Perhaps the numbers might shock you a little bit. So from a discovery of medicine to getting the medication into someone for a therapeutic benefit, normally it takes about 17 years. The exception is the vaccine we've seen most recently, but a lot of that technology has been very well established. So when the disease comes along, the technology can be used tailored to the disease. So I think that was an exception. So it takes a lot longer. And although Mark said we recruited ahead of target, the whole trial idea was actually came about in 2019, 2018. Took about a year to the funder, then took another 6 months to be set up, 5-year duration. By the time I write it up and actually present it, it will probably be coming close to 8 to 9 years. So it takes a very long time. We've obviously got ethical obligation after spending taxpayers' money as well as using patient data to communicate what our findings are clearly and also make sure that it contributes to overall body of science. So I think it is really important, no matter who you are. And also probably most important to our service users, our patient, it is our obligation to do this better. Apparently, up to 50% research was never published. So done, collected data, do the analysis, but never published. So a lot of wastage here. And actually, we need to ask ourselves, if we've consented a patient and got the data, even though sometimes it is very hard, and I've been through that myself, to get your research published, it is still our job to complete our agreement, complete our contract. 40% patient, this estimate by NIHR, is currently being treated with best evidence care. Evidence-based medicine's been around for a long time, but still, yet to this day, only about 40% of patients, less than half of a patient, are treated with best evidence. And rather shockingly, 14% of clinical trials have become standard practice. So what is stopping us? We have a lot of engaged researchers, we have engaged clinicians. What's the disconnection between doing research and getting into clinical practice? I'm going to try to answer that. It's quite a big topic. I'm going to split it to look at the trial design. Is there something fundamentally wrong with how we do trials? That means we can't use the results when we do it. Is there something fundamentally wrong with researchers? Are we just not doing our job properly? What about clinical community and our organisation? And in UK, obviously, we're talking about NHS. Is there something there that we're not doing so well? And then I'm going to just finish off with the role of the funder, looking at how the funder could help us or maybe hinder us in terms of implementation. This is a nice, colourful infographic. This is a integrated care board somewhere in the Midlands, which I have found on the website, and they describe the population they care for. Lots of small numbers there. But if you look at the male and female population there, it's not 50-50. And there are lots of various disability, and it tells you how it's changed from 2022, 2023. And then the whole list of small, next to the pie chart there is ethnicities. I don't know about you, but when I capture data, I didn't know there are so many different subgroups of ethnicity, but this is how the patient has reported their ethnicities. If we were going to design a trial that should reflect our patient population, we need to capture some of these. Surprisingly, the distribution of gender, ethnicity, disability or age group is a bit different from what you and I have experienced. According to NIHR, it's more a 51-49 male-female breakdown. If I was doing a trial in this area, I'm not going to be representative of the patient population if I've got a 50-50 split on male-female. This could look very different if we drill down to disease-specific patient populations. How do we make sure that when we design the trial, we do not put any unnecessary criteria or rules, which means that we cannot recruit more representative patient population? It is a real problem. This was a systematic review, and they took a 6-year sample of cardiology, mental health, and oncology trials, looking at the patient samples, and then they applied the exclusion criteria. And the bar chart shows you an age group breakdown of the amount of people when they compare the exclusion criteria to the patient population when they are ineligible to enter the trial. It's a shockingly high proportion of people. If you apply the exclusion criteria, means that they can never enter a trial. So we all know this is because randomized control trials are done under controlled ideal conditions. Safety is a real concern. We enter the exclusion criteria to protect the trial, to make sure people don't suffer side effects or at higher risk by participating in the trial. But that will mean that actually when the results come about, a lot of them are not applicable to a significant proportion of people in the population. So not representing real-world patients. And this is the argument that sometimes we're using observation studies and cohort studies, we may be able to get some data from those where we're currently not included in randomized control trials. So when someone is interpreting a trial, they could say, I don't really want to adopt your findings because you didn't look at the right patient cohort. It's not valid for my patient population. You can understand that. Other things, and a classic example, women. This has been highlighted quite recently, which is nice to see. In phase 1 drug studies, only 22% of participants are women. And it's slowly coming to realization that actually this means that most trials are done in healthy men. We've excluded women of childbearing age, and the childbearing age is a large cohort of women, as well as children, which means that when you come to phase 3 trial or aftermarket surveys, it means that women have reported more side effects because when they designed the trial, they were never part of the participants. So this can become a problem, and it also means that women may not have the best treatment available to them. This is FDA data in 2019. In 2019, they approved 40 new drugs. I'm trying to show you that this is not a historical problem. It is still a current problem. 40 drugs they approved that year. 16 out of 40 of them had less than 50% female participants. And then those are the participants there from 10 to 32%, small proportion. And these are the drugs that are suitable for men and women. They're not exclusively men disease. For example, bladder cancer. We know that women outcome are slightly worse than men at the moment. But some of the drugs are newer drugs targeted to bladder cancer has not had a representative proportion of women participants. This is a real problem. And I think we all have the collective responsibility to make sure, if ever possible, we should not exclude a significant proportion of our patient population, if we can. What about socioeconomic background? In this conference, we talked about disparity, health inequity, how we're doing. Anecdotally, we know we're not doing so well, but is there any data out there? This is some data from Manchester. So census data where they look at deprivation. So darker you are, the more deprived you are. This is where the hospitals are based, the red dots. So fairly, I think it follows the pattern. But then when you look at who contributes to research, becomes these little more orange colors there. They become much, much smaller. You can see that there's a whole area to the west, not covered. There's a whole area to the north, not covered. So the whole clinical research network are not able to recruit patients from those areas. And then matching to the socioeconomic background, you know that the patient we are able to reach and recruit, not representative of general population, if you drill down to socioeconomic background. And the other factors, the trial participants and the results are not valid when you talk into our clinical practice. And that's why perhaps a lot of trial results are not currently being taken up widely. What about the choices of outcomes? I think we've made great strides in the last 10 years using recommended outcome measures and not just what our favorite outcome might be. But it could be that outcomes are not very relevant. Mortality is easy to count, but patients also care about quality of life. They also care about functional outcome, and they're not so easy to count. A lot of trial designs, when you calculate sample size, mortality is the obvious one to go for. It's popular with the funder, but perhaps it's not the only important outcome for our patient population and our clinicians. Follow-up period may be quite short due to funding constraints, or you have a big drop-off of patients afterwards. So the people you're able to follow up to get those results are much smaller proportion. And then we know that we're now encouraging more patient-focused trials. So we co-design with our patient. We use patient-reported outcomes. But even using patient-reported outcomes, and this is from Mel Calver and her group in Birmingham, who are some of the pioneers of patient-reported outcomes, really working with patients to design outcomes that's relevant to them. But what they've found is that even when they use patient-reported outcome, this is in cancer studies, there will be up to a quarter patient who decline. So they think this is either not designed well or they decline to give that information. But then when we use electronic capture, something you and I will have in our pocket, in our bag, a significant proportion of patients are not able to use those patient-reported outcomes because there's an assumption that everyone got access to technology, Wi-Fi, internet in an equal proportion, but that's not true. In actual fact, that's not the case with general population. So the way we capture the outcome could mean that and interestingly, they also said that patient-reported outcomes are not validated in underserved groups because their contribution in creating the patient-reported outcomes was missing because they were not engaged to begin with. So even from a very expert group, it tells you that using what we think are the best outcomes may still have drawbacks. Sometimes we just don't get to the answer. You'll be familiar with this if you ever read a paper. The sample size is too small, we lost too many people, so we can't make a firm conclusion. If you do any statistical modeling, if you stop, it gives you a higher chance that you are not describing a true effect. And then what about this? More research or larger definitive trials needed. Always the last few sentences, all the paper Sari writes, is probably rather disappointing that when someone else read our research, all they can see that we are not able to affirm a firm conclusion. How are we expecting our results to then translate to clinical practice is a big ask and almost too much of a disconnect between ideal research setting and clinical practice. And then coming to our researchers now, so someone like me or someone like yourself who recruit to trials, I would say that we are probably not expert. My skill set is in critical care. My skill set is trying to write a protocol to address research questions. My skill set isn't necessarily about getting my results into clinical practice and making sure policymakers and guidance committees are aware of my research. I don't think I've had training in this area at all. And for majority of people, dissemination is, I do my trial, I come on stage, I write a paper, and you can come and listen to me, and please go find my paper. I'll give you a QR code. But what actually needs to happen is probably a two-way dialogue. So I've done the trial. I should go to the stakeholders, clinicians, and other healthcare professionals and say, how can we make use of the research data? How can I help you use my research, what we found, into clinical practice? But I don't think we currently do this. For NHR, for university and NHS, they're now looking for that impact. Without that dialogue in between, there is really, really hard and not really able to describe what sort of impact we will do. Getting grant funded and done, we need to be able to capture how it has changed practice or improved patients' lives. We can see that this takes much longer than a 5-year project. And as someone famous once said, the biggest problem is that you thought it's taken place. So as a researcher, written my paper, I've come to conferences, I've done my job, but that's probably a simplistic way of thinking about dissemination. This is from NIHR. They look at research patient benefit and program grants. They looked at top 5 common mistakes that researchers do for dissemination, not including right co-applicants with knowledge and networks. They're not talking about getting your professors in and other people in. They're talking about opinion leaders, people who are on the ground doing the job with the right committees who can make sure that your research get heard and is implemented. So on the ground, if you read this document, it actually says not in the academies and most likely outside your immediate network. So look for those people who can make your research speak to the right people throughout the research study, not until the end. Unbalanced research team, so very top heavy. Lots of important people, our friends, family, but what they want is other people. They also specifically say you need at least 2 PPI members and probably more, depending on your subject matter. Inappropriate delegation or dissemination engagement to your PPI and your project managers. They're not the people who can do this for you. You need real expertise. So from the word go, from in your team, get someone who has experience before translating research, doing knowledge transfer onto your team early on, and don't just delegate it to people who wouldn't have the expertise to do it. Over-reliance on written documents. We all want the 4-star, 5-star paper, but they clearly said that this is not enough. There is access issues, firewalls, paywalls, conferences, unless you can join online, are not accessible to everyone and only to those able to pay and take the time off. So we need to make sure we're doing more than that. Not enough resources given to dissemination engagements. Interestingly, they recommend 10% of your budget should go on dissemination. When I read that, I was a little bit taken aback because I don't think I've allocated that sort of budget. But we can always do better. It's not all about money. This is interesting. Top 5 things that we're not doing well. Probably just looking at my own work, I'm probably still guilty of at least 3 or 4 of those. Can do better. Communicating results. Journals, conference, as I said before, they are the traditional ways of communicating our results, but they're not the best. It still puts a lot of barriers. And it also requires clinicians and healthcare professionals to take time to go and look for those. They don't often have the time, energy, or inclination to do so. We need to make sure we do this better. And I think we are better. I've seen NAP7, there was podcasts, there's interviews, there's nice infographics. I think we are doing better, but there's still more to be done. Explaining complex stats is interesting to some, but we need to communicate this clearly to our audiences, subgroups, multiple outcomes, and then trying to explain and get across the ideas about negative trials. So the headline might be, we didn't find a difference, but there are still lots of things within the trial that is interesting and useful in clinical practice, and we should not forget those. And then here's a whole loads of stuff that are gobbledygook to people who don't know what this is, including me. There'll be increasingly difficulty. Intention to treat, what does that mean to other people who don't do trials? Bayesian analysis, something about known and unknown priors. Minimization, stratification, don't know what that means. Propensity score matching, immortal time bias, and all these platform basket umbrella. What does that mean? How can we do our job properly to explain what we call buzzwords in trial designs mean something to clinicians and people on the job? I think we need to translate this better, basically, translate to normal English. There's an example I found that I bookmarked. I was going to read about paracetamol for organ dysfunction. And this is the main results. This is the money survival curve. You look at that and I thought, wow, it looks different from what I expect. It takes quite a bit of knowledge and experience to understand this, just glancing at the graph. What we can do better is what journals are now doing, this visual data visualization, so very visual abstract. So this is what they do. And actually, these are created by data analysts visual specialists who understand how to communicate scientific concepts clearly. And I think, if you give you 3 minutes, look at that graph and 3 minutes, look at this, you can get a lot of information from this simple visual summary. Then there's what we call the money result graph. So we need to learn as researchers how to communicate research findings in this matter. Last but not least, conflicting results, different studies showing different things, maybe different countries, different way of designing. So it means that you don't really have a clear answer yet. So more research needed. So when that happens, you can do fancy things like network meta-analysis, and a lot of trials are now doing that because they all look at different research questions. They come together at the end to compare. And this is a meta-analysis looking at spinal analgesia for midline laparotomy. They can do lidocaine, IV, epidural, tap blocks, rectal sheath catheters all together and try to give a definitive answer to see which one has most patient benefit. So we can do better. There's also a new trial funded in April this year, looking at a better way of reconciling conflicting results from randomized trials. So there will be more research coming to help us find a way forward if trials are not given a definitive answer. Okay, look at our kindred community and an organisation. What can we do better? A lot of clinicians are sceptical about trial results because of everything I've just said. Population not right, outcome not great. They probably think they know the answers already. It makes a barrier to the community clearly if there's a skepticism or lack of equipoise to begin with. But I think we can do better. Most of us are trained to think logically based on facts. The more we can, the facts obvious, communicate in research, the easier it will be to communicate with them. The lack of time awareness is a real thing. You know, research are maybe further down the agenda now. So we need to bring it back up the agenda, make it easy for them to digest so that they are aware and they can make use of the information given to them. Other things that are harder to tackle, medical culture, traditions, and then the lack of infrastructure. So NHS is an organisation. Our infrastructure is not set up to have quick change. We are not Amazon or eBay. They famously did a research study by showing you different products and different ways. Depending on who you are, when you sign up, you consent to that. And they almost immediately find out which works and then they implement it straight away. We're not like that. We're not a commercial organisation. There's lots of moving parts. Lack of funding and time to implement change and change management is a real problem. That means some of the things we want to do never get done. Other things, with the right support, finding your champions, early adopters, starting from where it goes for a trial, finding your sites who are the most engaged, start talking to them and say how best we can tell them what the results might be. Get them together to be your implementation team. So these people can be the first adopters of your trial findings. Get them engaged on board. Provide training to them. So when you disseminate results, explain what that means and perhaps look at the local guidelines so that you could suggest changes to your local guidelines and work with them like partners. And then making sure your policy and decision makers are, again, on board at the same time. So these are things that we should do. And again, as I said, that's not something I'll currently regularly do, but we'll certainly look to do better in the future. It takes time and money. So what's our funders doing? NIHR is one of our biggest funder, biggest taxpayers' money. Most of our NHS research are done by NIHR, and they'd be very good to have a inclusion strategy. And they have done they started to measure the impact. So what they've done is measure what's happening now. In their funder study, so as I said before, I'll show you a picture of what a population look like. In NIHR funded trials, they think they've got 51-49 split of male and female, which is pretty representative. And this represents quite well the census in 2011. But it is 10 years since the census has been. And so although it looks quite representative, broadly representative, it may not be disease specific, but broadly speaking, quite representative. And good news is 90% of trials, more than 90% of trials are reporting this accurately. And then they look at ethnicity. And this is their funded trial. And then compared to 2011 census. So again, broadly representative. Broadly speaking, we do have a majority of predominantly white population, and they are predominantly the trial participants. As you go down to the other ethnicities, you will see that we are not recruiting as many representative patients from non-white communities. So, and I think when we do this is census data in 2011, if we do this now, the population might look quite different, and we may not be as successful as we've done in this report. Interestingly, when they looked at this, they were only able to get data from 60% of trials. We are not capturing the data accurately, and therefore there's no way to know whether we are representative. So what can we do? There are kits out there to help you communicate research. NIHR has got impact toolkits. It helps you decide who your stakeholders are, your efforts and impact by communicating with them. So there are toolkits out there that helps us researchers communicate our research better with our colleagues. There are now recommendations how to talk to patient and public. So in digestible, interesting graphics. So another example how we can communicate research a bit better. I'm going to finish now, and I think in my preparation of the talk, I've learned a lot. And I think the key things that we need for successful implementation is that researchers need training and support to do this properly. We're not the expert. I think we should put our hand up and say we need help. I think there is more space for implementation scientists and data specialists key stakeholders within the actual research team when the budget goes in, when the grant goes in, to make sure we don't fall off at the end. And this dissemination strategy needs to be right from word go. Have a think about how best to get your research out there, who are the people you need to engage, and make sure they're ready on the team when you go for funding. And I think from a funder's point of view, they need to think about not just funding the budget, but giving more support at the end of the project so that we can still go and do a knowledge transfer and measure impact at the end. Happy to take any comments or questions.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.